Hello, my name is Valérie Vilgrain. I have prepared this lecture with Ricardo Sartoris on the role of digital in imaging HCC. Today, indeed, we use mostly qualitative imaging, and the role of imaging in the management of HCC is threefold. First, detection and diagnosis. Second, staging and pre-op evaluation. And third, to assess the follow-up and tumor response. We see a growing interest in quantitative imaging, as shown here on the right. And what does it mean? It is an extraction of quantifiable features from medical imaging. So let's start first with the detection and diagnosis. We don't know much about digital approach for detecting HCC. I just want to share with you this paper, which is interesting but very preliminary, focusing at automated detection and delineation of HCC on a contrast-enhanced MR using deep learning. As you can see here, most HCC were detected by the algorithm. We know a bit more regarding the diagnosis. First, you remember that imaging is able to diagnose non-invasively HCC based on several imaging features: the hyper-enhancement on arterial phase, the washout, the presence of capsule, and the tumor size. We can either use the EASL criteria or the LIRADS that combine these four criteria. And then, based on presence or absence of these findings, we can assess a probability of HCC. LIRAD 1 will be very unlikely for HCC in patients at risk of HCC, while LIRADS 5 in red here is very, very likely to be HCC. And we see here hyperenhancement on arterial phase, followed by washout on portal venous phase. If we look at the average probability, we see here an increase in probability. Yet the problem we have with the LIRADS is we still have some percentage which is not so low of HCC found in LIRADS 2, unlikely to have HCC, and LIRADS 3. So the question is, how can we optimize and increase the diagnostic performance? Here, others have interestingly incorporated quantitative approach. First, they do the regular classical readings with LIRADS. Then they will use radiomics with machine learning signature and be able to differentiate a non-HCC from HCC. In France, we have been lucky to participate to a consortium which is called the HECAM project, multi-technological automated and quantitative evaluation, and we are able to now depict using the quantitative features in light green the hyperenhancement on arterial phase, as well as presence of washout here on portal venous phase and delayed phase. This is shown in dark green, as well as the other major features, the capsule and the necrosis. And our intention is clearly to use this algorithm either as a first step or as a second step along with the radiologic lectures. Let's see our preliminary results that have been presented to the North American Convention of Radiology. We have included 143 patients, and here you see the diagnostic performance of the algorithm for the arterial phase hyperenhancement, for the washout, and for depiction the enhancing capsule. Sensitivity and specificity of these features is quite high. And on the right, the ROC curve show that the three curves, in blue the hyperenhancement, in yellow the washout, and in green the capsules are not bad, and compare very favorably with the dots, red dots and violet dots that are the diagnostic performance by junior radiologists. So this is certainly something interesting, and we are going to work more on this automated depiction of the major features on imaging. Can we move forward? Yes, probably. We know that there are several subtypes in HCC with a very different prognosis: pseudoglandular, scurrirous, steatohepatic, macrotrabecular, as well as the IMTM HCC. And it would be very interesting to depict these changes by looking at the quantitative data. We know that there is substantial necrosis in the MTM HCC, but to date, we have not seen any radiomics or other quantitative methods to differentiate HCC subtypes. Another question is regarding the differential. We know that HCC is very close to hepatocellular adenoma, looking at the imaging features. So working with a group in La Charité in Berlin, we looked at the fractal analysis. What is fractal analysis? It quantitatively assesses the perfusion chaos by calculating the fractal dimension. And on the graph showing here on the right, we see here that the fractal dimension was actually different between hepatocellular adenoma subtypes. We have on the left HNF1 alpha, in the middle beta-catenin, on the right inflammatory. So this is the good point, but unfortunately we were not able to differentiate the inflammatory hepatocellular adenoma from hepatocellular carcinoma. So there is still work to be done. Now, it is also interesting to look at the pre-treatment evaluation and the prognostic factors. A very important prognostic factor is the presence of microvascular invasion. And microvascular invasion is still difficult to diagnose on imaging non-invasively. We know that some features have been described: arterial peritumoral enhancement, non-smooth tumor margin, peritumoral hypointensity on hepatobiliary phase. Yes, if we see at least two of these features, we could predict microvascular invasion with a high level of specificity. The problem is that there is significant inter-observer variability. So can we use quantitative data to solve the problem? Again, two studies, one focused on CT, the other one on MR, showed in a large number of patients that using segmentation of the tumor, but also segmentation of the surrounding liver adjacent to the tumor, it was possible with a high value of area under the curve to detect microvascular invasion. Again, we have to confirm this approach, but this could be extremely interesting. And when we talk about HCC, we do not always look at the tumor, but also at the surrounding liver. And we know that quantitative data are extremely important. This is the liver stiffness that we can assess using transient elastography, using ultrasound-based elastography. We know that for many years. We can move forward and use other tools in our centers. We are using routinely the liver surface nodularity, which is a sign of cirrhosis. But we have shown that it's not only a sign of cirrhosis, but it is highly associated with the severity of portal hypertension, as you can see in the graph in the middle. So this can be definitely used on routine pre-op CT examination in order to stratify patients and to offer the best therapeutic options. And now the last point is the assessment of treatment response. And I have taken two examples. First, the chemoembolization, which is a very important treatment, actually the most commonly performed in HCC. We assess treatment response with qualitative criteria, differentiating the non-viable tissue, the equivocal tissue, and the viable tissue. But we know that we lack a high level of diagnostic performance. Again, with the ECAM project, we were interested to automatically depict the hyperenhancement after conventional chemoembolization with lipidal deposition. As you can see in the two bottom images, we were able to define different components within the tumor. In red, the lipidal. In green, top green, this is the viable portion, and in the middle, the undefined. And then we could quantitatively assess the proportion of viable tumor. Another study from a group at Henri Mondor has evaluated the quantitative data using texture analysis of HCC in pre-treatment of sorafenib, and they have shown that there are factors that are predictive biomarkers of survival in patients. And among those factors, the portal-derived HCC entropy was independent predictive biomarker of overall survival. So again, very promising, but not yet confirmed. And with that, I would like to conclude. In the era of digital imaging, the non-invasive assessment of HCC is about to get a big boost in effectiveness, thanks to the quantitative applications and the deep learning algorithm. Studies showed the potential of quantitative imaging at different time of HCC evaluation, from detection to assessment of tumor response, and clinical implementation is now realistic when applied as two-step interpretation and indeed in synergy with a classical human assessment. Thank you very much.